Okay, welcome everyone. In place of our mesothelioma and lung cancer study day, we're hosting a series of webinars. Today we're joined by Professor Nick Maskell, who's a respiratory consultant at the North Bristol NHS Trust. And Nick's going to give us an update on the investigation of asbestos-related disease and recent trial results. So over to you, Nick.
Thanks very much, Annabelle. It's a pleasure to be here. I'm just going to share my screen with everybody so that I can show you a few slides. So I've been asked to review a few recent papers that I think are important in helping us investigate asbestos-related disease more quickly and appropriately, and just to talk about some recent advances which I think are useful for everyone to know when they are seeing patients in the clinic. So the first slide really talks about the importance of mesothelioma and how we are seeing increasing number of cases at the moment. So this basically is a slide looking by age group at the number of male mesothelioma patients that are dying by age per year. And we can see that actually we're now here sitting at 2020, and a lot of the patients that we're seeing in our clinic and diagnosing with mesothelioma are actually over the age of 75, and a lot of them are over the age of 85 now. And that's important because when they present with symptoms, they might not be able to undergo invasive investigations, and therefore for some patients we need to do simple things to help guide the diagnosis without putting them through too many invasive procedures. We're helped by 3 international guidelines that have been published recently. Everyone will know the BTS mesothelioma guidelines were published a couple of years ago in March 2018. They've now been joined by the ASCO guidelines, which is the American guidelines for investigating mesothelioma, and more recently the ERS have also published their mesothelioma guidelines, which are going to be formally presented at the ERS Congress in Vienna later this year. It's interesting because all 3 of those guidelines actually reviewed pretty much the same literature, and by and large the recommendations are similar across the guidelines, but there are some interesting differences that may well be made up by the different type of subspecial interests there are in each of the particular guidelines. In the BTS thorax guideline, we feel that the role for surgery for mesothelioma shouldn't be done outside that of a trial, whereas the other 2 guidelines state that in selective patients with early disease, surgery for mesothelioma might be appropriate. So it's interesting that the different guideline groups and experts reviewed the same papers but came up with slightly different conclusions. Hopefully we will be aided by the MARS-2 study, which is a large study that Eric Lim is coordinating across the UK, looking at the role of extended pleurectomy decortication in mesothelioma. And it's exciting to know that over 400 patients have entered that randomized controlled trial, and they only need 10 to 12 patients more until they will be closing, and after appropriate follow-up looking at the data. So hopefully we will have the answer of whether any form of surgery benefits patients with mesothelioma within hopefully the next 18 to 24 months. Taking us back a step, when you first see a patient with an undiagnosed undiagnosed pleural effusion, the first diagnostic step is often to perform an ultrasound and to obtain some pleural fluid and send it off for cytological purposes to see whether there are any cancer cells there. The cytologist will often see clumps of abnormal cells, and in recent years, advances in immunohistochemistry and immunocytochemistry have allowed the cytologists with greater clarity to tell us whether they think that this is an adenocarcinoma or potentially a mesothelioma. But often they don't see these abnormal cells in sufficient quantity to make a confident diagnosis of mesothelioma, and often we need to rely on obtaining a pleural biopsy. We know from this work from David Arnold in our group that was published in the ERJ in 2018, where 880 patients with undiagnosed unilateral effusions that had cytology sent that turned out to actually have a malignancy showed that actually if you had an ovarian, lung or breast malignancy, the yield from cytology alone was really very high, up in the 80s plus, whereas if you had mesothelioma down here, then the chances of you having an accurate definitive diagnosis on cytology alone was under 10%. And so we often would need to do more than just take a cytology sample. But the problem is, from my first slide, a lot of the patients that we're seeing are now frail and perhaps in their 80s, and it might not be appropriate for them to have any aggressive invasive investigations. We know from the BTS guidelines that when you've got pleural tissue, it is good to do at least 2 mesothelial and 2 adenocarcinoma immunohistochemical stains to actually confirm the diagnosis. And the guidelines also suggest that we shouldn't rely on cytology alone to make a diagnosis unless a biopsy is not possible, and that might not be the case, that it's possible because of their poor performance status. So that's why it's interesting that we now can test both cytology fluid and histology specimens for the BAP1 gene. So the BRCA1 associated protein, so the BAP1 gene, is a tumor suppressor gene and is mutated in many cancers, causing loss of expression. BAP1 protein is frequently lost in mesothelioma, especially if it's an epithelioid or biphasic mesothelioma. And we find that BAP1 is lost in approximately 56% of tumor samples. So as a standalone test, it's got a moderate diagnostic sensitivity, but what's really important is it's got an excellent specificity of 100%. So if on cytology we're finding that actually there has been loss of BAP1, then actually we can be confident that this patient's abnormal cytology cells do represent a mesothelioma. So BAP1's a highly specific marker for differentiating mesothelioma from reactive mesothelial proliferations, and it certainly helps us in our mesothelioma MDT meeting when we're looking at patients that are very frail and are not fit enough for a biopsy, that if the radiology is consistent with a pleural-based malignancy and the cytology is suggestive, and in addition BAP1 is lost, then that often gives us enough confidence to call the diagnosis of mesothelioma secure, even in frail patients. So that's the first thing that I wanted to talk about. And you can see on this image, this is a biopsy specimen where you can see on the right there has been BAP1 loss. So what about if the first pleural biopsy that you take is non-diagnostic? We know that actually CT-guided pleural biopsies and both medical and surgical VATS biopsies have a high sensitivity, somewhere between 80 and 95%. But often there are cases that we'll all be aware of where the first biopsy, even though we clinically suspect mesothelioma, has been non-diagnostic. Perhaps the biopsy wasn't deep enough to invade the fatty tissue. Perhaps the material was not in large enough quantity to make the diagnosis. That often occurs in cases of desmoplastic or sarcomatoid mesothelioma. And in those circumstances, we often need to go on and do a second biopsy. And so in this study that was run by Denisha Di Fonseca, who's now a respiratory consultant in Sheffield, this was a multi-center study that she presented at the Winter BTS and is currently being worked up to be published later on this year. But I wanted to share with you some of the slides that she presented at the Winter BTS. This was looking really at that group of patients, as I said, that basically have had one pleural biopsy that was non-diagnostic, where there was a clinical suspicion of underlying pleural-based malignancy, and the patient needed to go on and have a second biopsy. And she was looking at whether a PET scan would help target that second biopsy and improve the yield. This was a multi-center RCT that was based in the UK. There were 10 recruiting sites, and patients were randomized in a 1-to-1 fashion between having a PET and a biopsy versus going straight and having a CT-guided biopsy without PET imaging. The power of the study was that we needed to recruit 78 patients, and the idea was that we would recruit over a 2-year period and then follow those patients up for 12 months after their biopsy. The primary outcome of the study was the proportion of pleural malignancy correctly identified on this second pleural biopsy, and there are a number of other secondary endpoints that you can see on the slide here. These were the centres that recruited to the study, and we're very grateful to all of them for their effort and time in recruiting. A total of 78 patients were screened, and in the end we managed to randomise 59 patients over that period. So this is the consult diagram. As I said, 78 patients were screened and 59 were randomised, and 29 were allocated to the CT-guided biopsy group, with 26 undergoing a CT-guided biopsy in the end, and 30 patients were allocated to the PET scan, followed by a targeted biopsy of the area on the PET scan that lit up the most, and 25 of those had a PET targeted biopsy, and almost all of them were followed up appropriately in both groups. This is the primary outcome of the study, and if we look at the top graph to start with, the CT biopsy only group, there were 29 patients, of which the final diagnosis of malignancy was made in 19 patients, with the CT-guided biopsy making this in 15. So there were 4 false negatives, giving it a sensitivity of 79%. In the PET-CT group, there were 16 malignancies in total, of which 14 were correctly diagnosed on the PET-guided biopsy, and 2 were false negatives, giving it a sensitivity of 88%. I think this is interesting, not because it shows that the PET scan improved the yield dramatically, but that actually the chance of getting a definitive answer with a CT-guided biopsy after one negative one was actually very high, and higher than we were expecting in both groups. We had assumed that on the second try of a pleural biopsy, perhaps the yield might only be 50 or 60%. And so it really shows that actually getting a CT-guided biopsy with or without a PET actually yields a very high final diagnosis of malignancy in the appropriate setting. These are the 6 missed malignant cases. So from the CT-only arm, 3 of them turned out to be epithelioid mesotheliomas, and 1 was a sarcomatoid mesothelioma. And from the PET arm, there were 2 epithelioid mesotheliomas that were missed, and both of those, interestingly, had no SUV uptake on PET scan. When we looked and asked the radiologists whether, as a result of the PET, they had actually changed where they were actually going to biopsy the pleura, in 50% of cases, the pathologists felt that on review of the PET, their site of biopsy had changed. The PET did provide added value, and it upstaged the disease in 22%, and also showed some features that were highly suggestive of benign disease in about 1/3 of cases. So after an independent review, the overall added value from the PET scans was present in about half of the cases in the study. So I think that the conclusions of this is that there isn't a routine use of PET in second pleural biopsies in cases of suspected mesothelioma, so we don't need to be using it routinely, because the yield of doing a CT-guided biopsy seems to be much higher than we had anticipated. However, there are certain circumstances when a PET-CT may well add value. The first of those is identifying another biopsy site if the pleural abnormality isn't accessible. For instance, if there was just abnormal mediastinal pleural thickening with a high SUV uptake, you might suspect pleural-based malignancy, but you can't access that with a percutaneous biopsy easily. But if another area, such as an adrenal gland or a chest wall mass not seen on CT, is identified by PET-CT, then it might actually change the radiologist's opinion of where they can easily biopsy to obtain a definitive diagnosis. I think it also has a role in identifying multifocal disease, and if we identify that with a high pleural FDG uptake, then we might well be more confident that the underlying cause of this person's symptoms is a malignant one. If the PET-CT looks very bland, it might also help us in a benign situation decide that actually, although we would normally follow this patient up with interval scans for 18 months, we could perhaps reduce the number of serial CTs that are needed in those cases because of the reassurance of the completely negative PET scan. So the third paper that I just wanted to highlight is something that we all come across in the clinics, which is diffuse pleural thickening that we suspect is probably asbestos related. And by that I mean that we've gone through the other causes of diffuse pleural thickening, such as pleural infection, causative drugs, autoimmune screens, trauma, previous hemothorax, and decided that actually the pleural thickening is likely to be asbestos related. The next question we ask ourselves is, does it meet the CT criteria for diffuse pleural thickening, which is an area of pleural thickening that is 8 centimeters by 5 centimeters and at least 3 millimeters thick? And then the final question is this diffuse pleural thickening actually causing disability? Because for the patient to actually go on and make a asbestos related claim, we need to show that there is some disability that the diffuse pleural thickening is causing. And so this paper was looking at the physiological consequences of different distributions of diffuse pleural thickening on CT imaging. And 85 patients that attended our unit were actually screened for diffuse pleural thickening, and they all had workup, including an HRCT scan. Some of those patients ended up just having pleural plaques alone identified with no evidence of pleural thickening, and some had CT definition of diffuse pleural thickening, either involving their costophrenic angle or not involving their costophrenic angle, and some of them were bilateral and some of them were unilateral. So just going through this consult diagram, of the 85 patients that were screened, there were 21 that ended up just having pleural plaques, and they acted as our control group, and they also had lung function tests performed. For the patients that had diffuse pleural thickening by CT criteria, there were 37 of them. 10 of them actually had diffuse pleural thickening without any costophrenic angle involvement. 15 of them had unilateral diffuse pleural thickening with obliteration of the costophrenic angle, and 12 had bilateral diffuse pleural thickening with costophrenic angle involvement. Just so that you can see what we're talking about, the first two pictures here, A and B, are the same patient. The chest X-ray is showing that there is some mild pleural thickening that you can see laterally, but the costophrenic angles are well retained. And on the CT scan, you can see this small strip of pleural thickening, which actually meets the criteria for diffuse pleural thickening, but doesn't involve the costophrenic angle. C and D images are from the same patient, showing actually in this case there is actually some bilateral diffuse pleural thickening with costophrenic angle involvement, and you can see that on the CT scan as well, with some pleural plaques also noted. What was interesting is that when we looked at the forced vital capacity as a percent predicted in the control group, you can see that all of the patients had normal lung function. If we then took the group that had diffuse pleural thickening, but their costophrenic angles weren't involved, there was a fall in the FVC, although the confidence bars show that there was some overlap, but the fall was approximately 15%. If there was unilateral diffuse pleural thickening, but it did involve the costophrenic angle, then there was a further small drop in the forced vital capacity, and bilateral disease really showed that the FVC had fallen to about 70% on average predicted when you're talking about bilateral disease. Why is this important? It's important because there are some patients who cannot perform lung function tests in the clinic, and therefore it's difficult for us to know whether they are disabled or not with their diffuse pleural thickening. But this study helps us evaluate the type of reduction in forced vital capacity and spirometry that we would expect to see in different CT scenarios, so that if we only have the CT to be guided and the patient's symptoms and we don't have spirometry, then we still have a good idea of what sort of disability this type of diffuse pleural thickening will cause. It's also a good idea in the clinic that if you're evaluating a patient to try and obtain a 6-minute walk test. Obviously, some patients have mobility issues and they have different causes of their disability, but it is a useful test when correlated with someone of a similar age and sex to work out what their predicted 6-minute walk is compared to what they've actually managed to achieve. Those are the slides that I wanted to show. I'm just going to finish just by summarizing what I think we basically have discussed. I wanted to highlight the fact that mesothelioma is a condition that is still on the increase, and that the patients that we're seeing in our clinic are more and more often elderly, over the age of 75, often over the age of 80, and doing simple tests to confirm a diagnosis is often all we're able to do, and the use of BAP1 is very informative and useful in helping us make those decisions without the need to always go on and do a CT-guided biopsy. The second paper really showed us the value of PET scanning, and I think in individualized cases there is a role for PET scanning, but actually routinely using PET to target the second biopsy is not necessary. And the third paper was useful at evaluating diffuse pleural thickening and showing that even if it doesn't involve the costophrenic angles, diffuse pleural thickening can still cause a physiological decrease in your FVC. Thank you very much, and I'll hand back to Annabelle, but thank you for your time and listening.
Thank you very much, Nick. That was really interesting, and it's really helpful to be able to clarify the process that people will go through to get a diagnosis of mesothelioma in the first part of your talk. Could you give an idea as to how long it takes roughly from somebody with symptoms manifesting before they might get a diagnosis of mesothelioma?
Thank you, Annabelle. I think that most patients can get rapid access to the hospital setting by going down a 2-week pathway. So when patients often develop symptoms of breathlessness, they will often go and see their GP, who will arrange a chest x-ray that will often show a unilateral effusion, and then they will be referred under the 2-week wait because it's a suspected lung cancer to the clinic. We will often have arranged for them to have a CT scan prior to their attendance with us in the Pleural clinic, and then when we see them to begin with, we will take off some fluid for symptomatic relief and send that for cytology. And probably within the next 14 days, we will have obtained a pleural biopsy if they're fit enough for us to do that. And then they will be reviewed in the MDT meeting and their diagnosis relayed to them. So I think the process from being referred by their GP to having a diagnosis probably on average is 4 weeks.
Okay, thank you. And for those patients who perhaps not fit enough to undergo a biopsy, is there any implications in terms of their ongoing treatment from not having had a biopsy undertaken?
I think that's a good question. And if we're talking about cases of mesothelioma, if they're not fit enough to tolerate a pleural biopsy, it's very unlikely that they will be fit enough to tolerate any treatment such as chemotherapy that we might offer them. And therefore, by us not putting them through the biopsy or confirming the disease, we're not denying them of treatment options. What we are denying them of is them knowing where they stand. And I think a lot of patients suspect that they've got malignancy and would like that confirmed so that they know where they are. And often with frail patients, we can say that we are suspicious. We can say that we're worried that there might be an underlying malignancy, but if the cytology isn't helpful and the CT scan doesn't show definite pleural thickening in a pattern that we would associate with malignancy, then we often have to say to them, the best thing is to have an interval scan in 3 or 4 months' time, and for us to see whether there has been any progression of the thickening so that we can try and clarify what's going on. And they have to live with the uncertainty for that 3 or 4 months while that's happening.
Okay, thank you. In terms of pleural thickening patients, so you mentioned an increase in the numbers that you're seeing from mesothelioma diagnosis. Are you seeing anything similar in terms of pleural thickening?
I don't think we are. I think we're probably seeing steady numbers in that regard. As you know, diffuse pleural thickening is often the result of a benign asbestos-related pleural effusion that has occurred previously. And often the lag time between asbestos exposure and the development of these benign asbestos-related pleural effusions can be a shorter time period than perhaps mesothelioma. And so when someone has had an episode of benign asbestos-related pleural effusion, we might not at the time be able to label it as that because it's a diagnosis of exclusion. They will probably be worked up in a similar way to a patient if they're fit enough, where we're suspecting mesothelioma, but the biopsies come back as benign. And then there is a period of observation with interval scans before we actually can say to them with confidence, this definitely isn't a malignant process, but we do think it was related to your previous asbestos exposure and is a benign condition. So we're not seeing an increase in those cases, but often we can't tell them for definite that it's asbestos related on the first scan, and we have to wait until some interval scans have shown no progression before we could be more certain.
Okay, thank you very much. That's all the questions I had. Thank you very much for your time and for your talk, and thank you for joining us.
Thank you.